To the press conference this morning. We have 4 abstracts and 4 presenters. Each of them will present their work, and when they complete that, we will open it up for discussion. We'll go one at a time. My name is Paul Bunn. I'm from the University of Colorado, and my co-chair is
Harvey Pass from NYU. I'd like to start out with the first 2 abstracts. The first one is the SCAT Phase 3 trial, adjuvant chemotherapy based on BRCA1 levels in non-small cell lung cancer node-positive patients. This was a prospective trial that was presented this morning, investigating whether BRCA1 levels could determine the use of platinum or alternatives in stage 2 patients. And now we're going to hear from its author.
Thank you. Thank you for this opportunity to share these results with you and with media. This is an academic trial. This is a trial coming from a multicentric cooperative group in Spain and deals with the patient in the early stage non-small cell lung cancer. That means patients that are initially treated by surgery, and we know if there are lymph node involvement in the surgical specimen, then chemotherapy, post-operative chemotherapy, is the standard of care in clinical practice. Our group tests one hypothesis trying to customize the post-operative chemotherapy treatment according one prognostic factor that is well known, that is BRCA1. BRCA1 is a key component of one of the pathways of in the homologous recombination for the lesion in the nucleic acids, and we know that also BRCA1 could have an impact in the prognostic. That means tumors with high BRCA1 levels, the course of these tumors is poor, and low levels, the prognostic is better. So we know also that based on this fact, we can customize treatment, chemotherapy treatment. This is the design of the trial, and we include 500 patients that were randomized either to a control group or an experimental group with different chemotherapy treatments according the levels of this BRCA1. This is the number of included patients, 382 in the experimental arm with the 3 different treatments, 108 in the control arm. We have seen that according to the expression of this BRCA1, the tercile 1, that means low expression, is associated with female sets, with patient never smokers, and with the histology adenocarcinoma. In the opposite, tercile 3, high levels, are more frequent in males, in current or ex-smokers, and with the histology squamous. The main endpoint of the trial is survival. We have not seen significant difference. The hazard ratio is 0.9. That means overall survival of the control and the experimental group do not differ. But if we move to the patients with, if we see the patient, this is the control group, we can see that the group with high BRCA1 levels have a poor prognosis than the other 2. That is in the control group, where all the patients receive the same treatment. If we move to the experimental arm, where the patient receives customized treatment according to BRCA1 levels, then the survival is not so different for the three groups. In the subgroup with low BRCA1 expression levels, we have seen that one chemotherapy with these two drugs, cisplatin plus gemcitabine, is better than the other, cis-docetaxel, with a median survival that is 40 months for the cis-docetaxel control and 74 months in the experimental group treated with this other combination. And in the opposite, patients with high BRCA levels, the median survival was the same in patients that received combination cis-docetaxel that docetaxel alone. And that our conclusion is the trial is not a positive trial in terms of the main endpoint, that it's survival, control versus experimental, but we have validated the prognostic value of BRCA1 expression levels in this early stage non-small cell lung patients. And we have found that in the subgroup with low BRCA1 levels, one combination of cisplatin, cis-gem, was superior to the other, cis-docetaxel, and for the subgroup with high BRCA1 levels, maybe the cisplatin could be avoided, and cisplatin is clearly related to an increase with early and long-term toxicity. And in this subgroup, maybe this drug could be avoided, and this could be without compromise the survival of this patient. Thank you.
We'll take questions at the end.
At the end.
Our next abstract is from John Edwards, the use of the IASLC lung cancer staging project to actually look at the impact of uncertain R, or the degree of resection status. And John presented that this morning. John?
Thank you. So thank you for the opportunity to share this again. So the IASLC lung cancer staging project has been going for many years. And what we have done in this work is to interrogate the data set as carefully as we can to look at the markers of uncertain resection that have previously been proposed. So in 2005, Dr. Rami Porter, Dr. Wittekind, and Professor Goldstrahl put together a proposal paper on behalf of the committee which defines the criteria you see on the right for those cases where otherwise the tumour was free in terms of the positivity of margins, but where there were criteria that seemed to potentially give rise to a less than certain resection margin, which they termed an uncertain resection margin. And those were cases where the intraoperative lymph node staging was less rigorous than the standard of systematic lymph node dissection or lobe-specific systematic lymph node dissection, where the highest lymph node was positive, or where the bronchial resection margin showed carcinoma in situ rather than invasive carcinoma, just carcinoma in situ, and where pleural lavage cytology is positive, and this is where saline is instilled into the cavity at the beginning or the end of the operation, and the lavage that is suctioned is then sent for cytological analysis. What we've done in this is to use the 8th edition database, which started off as 94,000 cases, but there were 14,712 cases for whom full data were available. 85% of these cases were from Japan, but the rest were from over 50 institutions around the world. And cases were assigned to the uncertain status according to the criteria that we've just discussed. It's important to realize that we didn't have the ultimate holy grail of the highest lymph node being involved, and hence used the highest lymph node station. And when we looked at the conventional R status, we can see that the R0 cases clearly did very much better, as one would expect. But the numbers were actually relatively small of R1 and R2 cases in the database, and there was not a significant difference between those two, but that may just be due to the size of the study not yet being large enough. And when we looked at how cases were reassigned to the uncertain category, 56 cases were hence put in that, and the vast majority of those cases was due to lymph node dissection technique being less rigorous, and that was in 95% of the cases. But there were still decent numbers of cases, for example, those with the highest station being positive, that went into that group. And when we looked at the highest lymph node station positive cases, you can see that there was a significant difference in those that were otherwise termed R0, where they were positive in the red line here, second down, compared to those that were negative. And more than that, when we looked at the R status in total, in the node negative cases, there wasn't quite a significant difference, but in those that had a node positive status, there was a significant drop in survival in the R uncertain cases, which accounted for a 20-month difference in median survival and a 10% difference in 5-year survival, with a hazard ratio there of 1.27. So the take-home message is that 56% of cases in this database were coded as R uncertain. The majority of cases were due to intraoperative staging being less rigorous than the ideal. And in those cases where the highest station was positive, the median survival was 14 months less compared to those where the highest station was negative. And in the node positive cases, median survival was 20 months less compared to the R0 cases. The numbers in the other categories are quite small, and hence that leads to the need in the future for getting very high quality data into the database. And hence that is a drive that the staging committee will be making to ensure that all institutions put in the highest quality data that we can to allow us to evaluate these further in the future. But what we've done in this work is to get as much data as we can out of the very large database that already exists. But more than that, the issues are that highest quality staging, if we want to show that our survival rates on an institutional basis are the very best, then we need to do our best to make sure that we do good lymph node dissection and perform high quality surgery. And if we are also analyzing trials such as we've just heard, in which surgery may be part of the arm, it's very important that we have an assessment of the quality of surgery in the trial protocol so that we can ensure that that's taken account of in case there are differences between the groups. And that's something that's been done in the Lung Art trial and the PEARLS trial, and we propose that these techniques are included in other studies as well. So that's the end. Thank you.
Thank you, John.
The next abstract is the correlation of DLL3 expression with high-grade pulmonary neuroendocrine carcinoma, clinical pathologic features and prognosis by Dr. Yan from China.
Thanks, Paul. Well, this study is focused on the correlation of DLL3 expression with high-grade neuroendocrine carcinoma, clinical pathological features, and prognosis. All the authors declared no conflicts of interest. Well, as we know, RUT-T is a promising DLL3 targeted congregates for small cell lung cancers. This encouraging trial reported last year also recruited 8 patients of large cell neuroendocrine carcinoma. So small biopsies are often used in clinical practice to determine the high-grade neuroendocrine carcinoma diagnosis before treatment. Therefore, we detected DLL3 expression in paired biopsy and surgical specimens in order to adjust the scoring system in biopsy specimens and the correlation with high-grade neuroendocrine carcinoma clinical pathological features and prognosis. A total of 378 patients with the novel high-grade neuroendocrine carcinoma was recruited, including 43 large-cell neuroendocrine carcinoma and 335 small cell lung cancers, there are 3 subgroups. Both 43 large cell neuroendocrine carcinoma and 402 small cell lung cancers have paired biopsy and surgical specimens, and the resting 293 small cell lung cancers with only small biopsies. Well, figure 1 shows the representative DL3 expression on surgical specimens. The left 4 pictures is from a large patient with large cell neuroendocrine carcinoma, and the right 4 pictures is from a patient with small cell lung cancers. Both cases displayed the intratumor homogeneous distributed of DL3. One compared the DL3 expression between paired biopsy and surgical specimens. No differences were found of DL3 expression between paired biopsy and surgical specimens in large cell neuroendocrine carcinoma, and similar results was also found in small cell lung cancers. And the DL3 expression level in small cell lung cancers was significantly higher than that in large cell neuroendocrine carcinoma. And the small cell lung cancers with low DL3 expression seems to experience a superior overall survival compared with high DL3 expression level group, but with the differences, however, not reaching the statistical significance. Well, small cell lung cancers with high DL3 expression patients were frequently male smokers and TTF1 expression, and no correlation was found between the DL3 expression with clinical characteristics in large cell neuroendocrine carcinoma. And the take-home messages: biopsies is a reliable material for evaluating DL3 expression. High DL3 expression in small cell lung cancers was correlated with patients' history of smoking, TTF1 expression, and poor survival trends. Further evaluation of the scoring system for predicting DL3 targeted therapeutic efficacy and the clinical significance of DL3 expression in high-grade neuroendocrine carcinoma are warranted. Thank you for your attention.
The last one is a study called Pacific, which is a randomized trial in patients with stage 3 non-small cell lung cancer, abstract 10762 by Dr. Hui from Australia.
Thank you. Thank you for having the opportunity to share this data again. I'd like to present again the results of the patient-reported outcomes with durvalumab after chemoradiation in locally advanced, unresectable non-small cell lung cancer data from the Pacific study. My disclosures on this slide. So durvalumab is an anti-PD-L1 immune checkpoint inhibitor, releasing the patient's own immune system to fight against the cancer. And up until now, that the 5-year survival rate for patients with stage 3 non-small cell lung cancer, confining the disease within the chest without any spread to other organs or elsewhere outside the chest, was only 15%. So this Pacific study, the main study results over here were already published in New England Journal of Medicine and presented at ESMO last month. So the impressive data is that that durvalumab was superior as compared to placebo, with significant median progression-free survival of over 11 months as compared to placebo, from 5.6 months to 16.8 months, with hazard ratio of 0.52 and a p-value of less than 0.001. Pacific is the first study bringing this class of immunotherapy to earlier stage non-small cell lung cancer, adding durvalumab for 12 months after the standard concurrent chemoradiation for this earlier stage group of patients. So patients receiving durvalumab also had a lower instance of new lesions, including new brain metastases, compared with patients receiving placebo. Although we had found that durvalumab was well tolerated with a manageable safety profile, we believe it is important to hear from the patient's perspective, and therefore looking at patients' reported outcomes, where patients would fill in questionnaire at different time points throughout the study and on 30 days after discontinuation of the study drug. As you can see here, that the scores for physical functioning and global health status, quality of life, was maintained and stable throughout the study over the different time points. And when we look at the two arms, there was no difference between the two arms as well. This is a busy slide, and I'll take you through that. This is actually looking at time to deterioration and odds of improvement. And for statistical term, that confidence interval would be the horizontal line, and if it's crossed the line 1, that's the line of no difference, that's really suggesting that there is no difference between the two arms. So generally, you can see that for functioning and different symptom items, there would be no difference between the two arms, apart from the highlighted two symptom items. For time to deterioration is pain symptom, but if you look at the other additional pain items like chest pain, shoulder pain on one questionnaire LC13, or another pain item on C30, there were no differences. Similarly, for appetite loss, there was a significant difference, but both actually favoring durvalumab arm. So the take-home messages. In summary, patients' quality of life was maintained with durvalumab compared to active surveillance, which was the standard arm on placebo arm, after chemoradiation in patients with locally advanced unresectable non-small cell lung cancer. Changes from baseline for key symptoms was minimal in both arms, and clinical improvements in alopecia and dysphagia, which I didn't mention here, but presented in the main presentation earlier, were likely due to resolution of toxicities related to prior chemoradiation, which all patients received before they came on the study. Besides appetite loss and other pain items which favored durvalumab, there were no differences in improvement rates or time to deterioration. So we conclude that no, it is indeed pleasing to see that adding durvalumab for 12 months after chemoradiation did not compromise quality of life. And alongside with the positive efficacy and safety data from PACIFIC, our patient-reported outcomes findings further support the clinical value of durvalumab and the use in this earlier stage non-small cell lung cancer. Thank you for your attention.
So I'll now turn it over to questions, and we'll start with the first presentation.
Questions to our first presenter on the SCAT trial?
My question is, was your statistical design such that it could only compare control arm to experimental arm? Or was it also powered to compare the 3 experimental arms with each other prospectively?
The design for the main endpoint was only to compare survival, because it's in early stage patients, from comparing control versus experimental. But we have a pre-specified sub-analysis comparing the different subgroup of the experimental. But the size, the number of included patients do not allow to have firm results in these secondary effects, mainly in the non-inferiority comparison in the high in the subgroup of high expression level, where probably need to be tested in a specific trial. If in this case we can change clinical practice and skip cisplatin, but our trial has not the sufficient size to make this type of comparison non-inferiority for this subgroup.
Could you tell us how the BRCA1 was measured, the platform, and how you got the levels?
Yes, the BRCA was measured through the RNA expression in a central lab. That is feasible in postoperative setting because we have the lung, the tumor, we have sufficient tumor tissue to evaluate and to measure that. This kind of customization is more difficult to implement for metastatic disease because usually the lung cancer biopsy are smaller and don't allow perform this kind of techniques. But this was not the main problem. We use a central lab. We send the sample to the central lab, and the problem, or a minor problem with was the 91 of the 500 patients we do not express sufficient BRCA1. So it could be explained that this patient have low BRCA1, but this patient were excluded from the trial if we were not able to measure the BRCA1 expression.
So this gene can be mutated. This gene can be expressed at the gene level and at the protein level. So do you know if any of the patients with low expression had mutation, or?
Well, no, the mutation of this gene was not assessed in this trial. It was only the expression levels, the mRNA expression levels.
Right. So and you didn't look at protein either.
Yes.
So you decided to put the patients into 3 groups rather than 2 groups or 4 groups. So why did you put them in 3 groups as opposed to high and low, 2 groups, and that cutoff, do you have any validation that cutoff that you used is reproducible and is the right cutoff to be using?
Yes, the cutoff level comes from a previous experience in retrospective analysis of patient in our group, both in operated patients in early stage and also in metastatic disease. We previously established the cutoff level according this retrospective experience.
So you concluded that you didn't have the power to really show in the high expressors that docetaxel is as good as a platinum doublet. How would you propose to go forward to answer that question? And is your group planning to try to answer that question?
Well, our trial was an academic trial that we are thinking about to try to design a specific trial for this high expression BRCA1 level in order to establish if we can skip cisplatin. But it is difficult because for an academic trial in the adjuvant setting, we need a longer time to have to expect the results. And now currently, as you know, probably the interest has moved to immunotherapy in the adjuvant setting. But I think if we could, if we might avoid cisplatin for a subgroup of patients, this could be interesting, and this is warranted to continue the research in this field.
So let's move on to our discussion of the ISL database that showed discrepancies with the R value, the complete resection and uncertain resection questions. Dr. Fernando?
So, Dr. Edwards, I was curious on the use of pleural lavage that you indicated, what the adoption by people contributing to the database was of pleural lavage, and whether you looked at whether pleural lavage was ever positive when there was no nodal disease in stage 1 patients.
So we do have the breakdown for that. I'm unable to, in the time available, to have presented the complete breakdown of that. There was an association with T-stage. I can't remember off the top of my head in terms of end-stage if there was, but the number of cases that had pleural lavage cytology was quite small. It was about, I think, 1,100 cases out of the 14,000 that were performed, and that was primarily through one of the Japanese registries that did it in a high proportion of cases, and one of the other institutions. So it's something that is not common practice, and without a lot more data, it's quite difficult to come to any firm conclusions about pleural lavage cytology, but we used it to reassign some of the cases, as you saw, as that was what was proposed in the 2005 paper.
Thanks.
So, John, lack of data or insufficient data is always a problem with registries. And it could start right at the beginning at the place, or it could be, conscripted when you're writing doing the fields. Now, how do you propose to help with this? What can be done? Nodal disease is where you're struggling with first. So, what are your suggestions to try and decrease uncertain R status going forward?
Sure. So I think there are key points according to each of the different criteria that are proposed. And obviously the biggest one that we saw was the less than rigorous lymph node staging. Now I appreciate in different healthcare systems there are different drivers to that. But hopefully by promotion of this paper will allow surgeons and those pathologists to reflect on the quality of lymph node staging that has been performed, and see that actually if we want our own institutional data to be as good as possible, then performing good lymph node staging is a way of achieving that. So almost gaming, using stage migration as an effect to ensure that your institutional data is as good as possible. So one aspect of it is for institutions to have their data compared, and that's something that, for example, in the United Kingdom, we're doing that through the Lung Cancer Outcomes Project, where we are comparing data, and the intention will be through that and the National Lung Cancer Audit to compare stage by stage data. So I think that type of initiative is a very significant way of reducing the uncertain nature of lymph node dissection in the majority of cases.
Yes, sir.
I have a related question. First of all, it's sobering that more than half the patients are uncertain in this day and age, and since that's probably not about to change quickly or drastically, and we have been following largely based on port meta-analysis, a policy of never offering radiation to node-negative patients, while the safety of radiation has gone up tremendously over time. Do you think there should be some consideration for doing a randomized trials of post-operative radiotherapy or not in our uncertain patients?
Well, I would like to see our uncertain cases. I mean, there are those that are due to less rigorous lymph node staging, and there are those that you can't avoid. So something like a bronchial resection margin with carcinoma in situ, unless you're performing frozen section analysis all the time, we routinely won't be able to eliminate those. But hopefully with the other cases, we will be able to drive down the R uncertain rate and find out what an acceptable level would be. So hopefully that is the aim. But it's really through greater data collection that we'll be able to answer many of the questions that are raised in this work.
Thank you.
Can you explain to the audience the difference between the number of lymph nodes positive and the number of stations, and why the surgeons haven't said it's the number of stations that's important, and what is the minimum number of stations that need to be sampled?
So, I mean, there are data looking, as we saw in Dr. Kernstein's commentary, looking at the number of lymph nodes that are taken. The difficulty is that there is variety in the pathology assessment that's performed. There's variety in the degree to which lymph nodes are collected and sampled at the operation, and there are techniques vary. And so one thing that would be nice to do with this and other aspects of the staging project is to try and come up with standard recommendations in terms of the intraoperative staging. And there are plenty of proposals out there through certainly in Europe, and I'm sure in the US as well, position statements trying to drive this. But actually I think a good role for the IASLC is to try and standardize the standards.
The other thing that's a problem, at least in the United States, is that the correlation between the operative note and the pathology report with regard to the number of stations looked at really doesn't correlate at all.
Sure.
And the other thing is that may be a problem because you may have actually looked at the lymph node, looked at the station, but there were no lymph nodes there. And according to the Goldstraw paper, that should actually be recorded in the operative note because that is looking at a station. There were no lymph nodes.
Okay, I think we'll move on to the next abstract. So questions from the audience for Dr. Yan about DLL3. So when you are looking at tissue, there are sort of two issues. One is, what did you do about heterogeneity? So how did you pick the area to be scoring? And how did you pick the H-score cutoff? So in H-score, they took the fraction of cells, 0 to 100, that are positive, times the intensity of staining, and multiplied them together, and you get an H-score. But you can get an H-score of 0 to 400, and they picked one cutoff. So the question is, how did they pick that cutoff? And is that cutoff based on looking at the section that's got the most brown, or how did they deal with, because you may have one section of the tumor that has a lot of brown and another section that doesn't have very much brown. So how did you deal with heterogeneity, and how did you deal with a cutoff value?
Well, the cutoff, the H score was determined by the two pathologists, but not by the program or others. And the optimal cutoff for the H score was determined by the best survival, the overall survival of these patients, but not by the drug response.
So in your study, you found that the expression was a bit higher in small cell than in large cell carcinoma, and there's a treatment that's designed for people with high levels. Do you think that Rova-T, that antibody drug conjugate, should be tested in large cell neuroendocrine, and should the cutoffs be the same if that drug is tried in large cell neuroendocrine?
Maybe not. The cutoff for the DL3 expression, it should be determined by the drug response, but not by the survival. But the Rova-T is not available in China. So in this study, the optimal cutoff is determined by the overall survival. So in the future, maybe the cutoff value should be, this scoring system, including the cutoff value, should be further discussed.
I think it's very interesting that you looked at high-grade neuroendocrine
Yes.
tumors, and this is a spectrum of tumors
Yes.
like this. So my question is, have you looked at the expression in lower grade, specifically to try to differentiate between typical and atypical carcinoids?
Sorry, we did not that study.
Okay, any other questions for this abstract? So maybe we can turn to the last abstract dealing with adding durvalumab to chemoradiation therapy for stage 3 non-small cell lung cancer. Questions?
I don't want to monopolize, but not seeing any other volunteers. My question is not per se about your quality of life, but the overall result of the study. Maybe you may or may not want to answer this, but any speculation about why the control arm did so poorly?
Right. You're actually looking at the progression, the interim analysis of the progression-free survival of 5.6 months. So what actually happened is now it is counted from the time of randomization. So when you actually look back and look at other concurrent chemoradiation studies, it's actually from the time of randomization before the patients actually started their concurrent chemoradiation. So if you add on like 6 to 7 weeks of concurrent chemoradiation, and then the patients were subsequently randomized about from 1 to 42 days. So the initial protocol had it within 2 weeks that the patients had to be randomized, and then very soon that we thought it was just too tight a schedule. So the amendment actually allowed patients to have the randomization within 6 weeks, 42 days. So if you add on another 12 weeks, then you would be able to actually say 5.6 months plus another 3 months, which would be what we normally would expect. So in fact, it is really reflecting what we normally would see from standard chemoradiation.
I mean, my feeling is we expect better than that, but I think that gets it closer to
the
norm.
progression-free survival, yeah.
So for those in the audience that don't know, this is an abstract related to a study that is going to change practice. And the goal of our treatments for any stage is to cure patients. And the hope is that adding immunotherapy in earlier stages is going to cure patients. But there's quite a few things that were not in this particular abstract. So perhaps you could just review what were the primary endpoints with an S of the trial.
Yep.
And what has been presented so far.
Right. So the primary endpoints, co-primary endpoints, there are 2 endpoints. One is the progression-free survival and the other one is overall survival. So the interim analysis was on the progression-free survival. There will be more updated progression-free survival data that will come. And the study remains blinded at the moment. That's the most important thing for overall survival analysis, which hopefully will get that data according to the events. So if it's driven by the events, if we had enough events, then there'll be time to actually look at the overall survival analysis.
And you presented one of the secondary endpoints, namely
Correct.
patient-reported outcomes. Maybe you could say what the other secondary endpoints of the trial
So
were.
the other secondary endpoints pre-specified included objective response rate, the duration of response, the time to development of distant metastases, as well as the safety and tolerability. Those were actually presented at ESMO a month ago, as well as published in New England Journal of Medicine. And they all showing that durvalumab provided superior efficacy, including all those secondary endpoints as well.
So in your study, you know, one of the things that you worry about when you give radiation is late pneumonitis.
Correct.
And one of the side effects of immunotherapy is pneumonitis. In your particular study, you didn't mention this, but dyspnea was worse in the group that got durvalumab. Now, it wasn't statistically worse,
Okay.
but the hazard ratio was higher than 1 for dyspnea. And so you didn't present the toxicity, but maybe you could discuss pneumonitis in this trial. I know it was presented at ESMO, but...
Sure, understand. So what happened was at ESMO, we particularly, as investigators, really concerned, as Dr. Bunn mentioned, about pneumonitis, whether the patients would end up having more likelihood of radiation pneumonitis, whether durvalumab would add onto it even more so. We actually seen in safety data that durvalumab had ended up with a slightly higher, about 30%, 33% from memory, of any grade pneumonitis. It's mainly grade 1 and 2, whereas when we looked at grade 3 and 4, there was no difference as compared to the placebo group. So we believe that looking at pneumonitis, there was no significant worsening of high-grade pneumonitis as such. Now, when we looked at the patient-reported outcomes, we particularly wanted to look at dyspnea as well. The confidence intervals actually crossed the line of no difference. So in general, we don't think that there is any difference. And we looked at the time to deterioration as well, and there was no difference as well when we plotted the Kaplan-Meier curve that I didn't actually show in my presentation. There was also, didn't take shorter or longer for patients on durvalumab to the time of deterioration as compared to placebo.
Now, at the 2-year mark in your progression-free survival, you had about 40% of the patients in the treatment, the durvalumab arm, who hadn't progressed yet. But that means 60% had progressed. One of the things that we like to do, if possible, is to select patients who are most likely to benefit. So in metastatic disease, people have been looking primarily at PD-L1 expression or tumor mutation burden. In this particular trial, was there any look to try to see which are the patients that are most likely to benefit in terms of long-term PFS?
Well, all patients were, all comers actually managed to get on the study. So we've got the benefit to actually have a look to see whether PD-L1 could be a biomarker. And when we actually looked at progression-free survival as such, that with the interim analysis, with the forest plot that was published in New England Journal of Medicine, we could actually see that both patients who actually had PD-L1 less than 25% or at least or over 25%, there was no difference as such. Both groups, the subgroup analysis showed that both groups had the benefit. So somehow at this moment, what we had looked at was mainly the PD-L1 status and other clinical pathological markers that didn't seem to actually suggest any ways of selecting the patients who may benefit more so. But whether other biomarkers that we actually know in this arena, there have been quite a number of other biomarkers that have been looked at, for instance, mutation load, the mutation burden, or gamma signature and immune signature. All those things is really as an exploratory thing that we may look at in the future, but at this moment in time, unfortunately, we haven't really got any biomarkers that would select the patients. Or you can actually say, fortunately, we can possibly recruit and suggest to all patients right now who may actually have this possible benefit. And the most important thing from the patient-reported outcomes is that we're adding 12 months of durvalumab to standard treatment that managed to provide superior efficacy, that we managed to see that there is no compromise on the patient's point of view in their quality of life.
And the last question would be, when are you expecting enough events that you're going to present the other co-primary endpoint?
We're hoping next year, but I don't know yet.
Okay, well, I think that ends the press conference. I'm sure if you want to have individual questions, the speakers would be happy to answer them. Thank you to the speakers, and thank you for the press questions and so on. Thank you.